Hello, my name's Claire Higham. I'm an endocrine consultant at the Christie Hospital in Manchester, and much of my focus of my clinical and research work is around bone health in oncology patients. So I'm sorry that I couldn't join you in person this morning, but I am hopefully over the next 10 minutes or so going to run briefly through the section of the best practice pathway for pelvic radiation disease that relates to bones. I'm particularly going to be focusing on radiotherapy related insufficiency fractures, as avascular necrosis is a much less common consequence now as the radiotherapy fields have changed over time. So I'm going to start by describing a case which just helps to set the scene really for these guidelines. So this is a lady, a 57-year-old lady who had vaginal squamous cell carcinoma. She had surgery and then followed by standard treatment with radical pelvic radiotherapy and volt brachytherapy. Around 12 months after she'd had her treatment, she developed what she described as sudden onset pain, which felt like a deep pelvic bony pain, almost like she'd been kicked by a horse, and she was struggling then to mobilize and get out of bed. So she went on to have an MRI scan to investigate this pain, which is good practice, as we'll see. And this found that she had no evidence of a recurrence of her cancer, which is obviously a significant concern for most patients if they develop pain this soon after their radiotherapy. What the MRI scan did show on this T1 weighted coronal MRI, we can see here, so bilateral hypo-intense bone marrow signal, and we can just see the fracture lines through this. And her pain was consistent, and that the MRI was consistent with bilateral pelvic insufficiency fractures. So as part of the service quality standards and clinical audit measures that you can find within the bone section of these guidance, we find that we've described that all patients with pelvic pain post-pelvic radiotherapy should be referred for an MRI scan. And the cause may not always be fractured, but it is very important that we rule out recurrence of the cancer itself. So just a little bit background about pelvic insufficiency fractures. They're common actually after pelvic radiotherapy, and we've known about them for some time. There is literature going back to the 1990s and earlier, which describes these fractures, and over 1,000 patients with fractures have been described in the various literature over the years. We know that the incidence of RRIFS varies in these publications depending on whether asymptomatic and symptomatic fractures are described, whether the imaging that is performed to diagnose the fractures, the underlying cancer and the treatment. But what we do know is that overall there's around a 4 to 20% incidence of radiotherapy-related insufficiency fractures following radiotherapy, and that this is across all of the pelvic cancers that occur, and also even with newer techniques such as proton beam or IMRT type radiotherapy. So what else do we know about these radiotherapy-related insufficiency fractures? Well, we know that their location is generally within the sacrum or the sacroiliac joint, which is much less likely in the pubis and acetabulum, etc. This is different to osteoporotic fragility pelvic fractures, which usually occur in older females, where they're more likely to occur in the pubic area. So we think that this distribution within the sacrum probably relates to the intensity of radiotherapy in this region, although it's not fully established. We know that they happen generally between 3 months and 3 years following radiotherapy, although they can happen a little bit earlier or later than that. This is the majority happen within this time, so it should be thought about when patients present with pelvic pain during these years. Just in terms of the symptoms within the guidance, we have tried to look at this in a little bit more detail. So the pain often presents where the fractures are. So the patient will describe the pain in the region of the fractures. It can often be described as intractable lower back or pelvic pain, and often radiating down into the buttock, groins or legs. It can be worse on movement or after weight bearing, and usually settles on rest. So just some of the features of the pain you might want to ask the patients about. So how do we diagnose a radiotherapy-related insufficiency fractures? As we've seen, that any patient presenting with pain in the pelvis following radiotherapy should have a pelvic MRI scan, which will which will help us exclude recurrence as a cause of the pain, but is also very good, in fact, the modality of choice to look for insufficiency fractures. They can sometimes be seen on plain X-ray, although this has low sensitivity and specificity, and I would not rely on this. Some patients, if they can't have an MRI scan, or the MRI scan is inconclusive, a technetium scan can be helpful, and particularly if it shows what's called the classic Honda sign, although we rarely use this now. And PET-CT, if we can't have an MRI scan, or if patients have a PET-CT for other reasons, is a very sensitive way of picking up these fractures. So again, just to emphasize, part of our audit guidance would be that all patients with pelvic pain post-radiotherapy are referred for MRI, and MRI is the modality of choice for diagnosing insufficiency fractures, and we've just described here some of the diagnostic features that you might see in this regard. So for patients who have radiotherapy-related insufficiency fractures, can we predict which patients are going to get these? And the answer is at the moment, no, although there are two recent meta-analyses which do look at the risk factors for patients who are going to develop RRIFs. And this paper from 2020 showed that 3 risk factors came out from their meta-analysis of around 7,000 patients, showing that patients who had osteoporosis, those that were postmenopausal, and those that had diabetes were more likely to develop insufficiency fractures. However, there's only been one prospective study currently looking at insufficiency fractures, and what we find with this is that out of the 200 patients in this prospective study, 16 of them developed a RRIF. And these patients actually had a bone density measured at baseline, which is the gold standard for looking for osteoporosis. And only 4 of the patients actually had osteoporosis. So you certainly don't have to have osteoporosis to develop a radiotherapy-related insufficiency fracture. The remainder of the patients did have osteopenia or low bone mineral density, although most of these were actually normal for age. So again, you don't have to have osteoporosis definitely in order to develop a radiotherapy-related insufficiency fracture. This study also showed that actually the percentage of patients who developed osteoporosis or osteopenia over time in this prospective study increased. So there may be some impact of the radiotherapy itself on bone density. Other risk factors that have been picked out in other studies are age. So the older you are, the more likely, as we've said, postmenopausal status, also smoking and a low BMI are probably related to developing RRIFs, but we don't have any good way of actually defining which patients. And certainly we have patients, and I've seen quite a number, who are young, premenopausal, don't smoke, and who've got normal bone mineral density. So you don't have to have any of these risk factors, in fact, to develop radiotherapy-related insufficiency fractures. So if we have a patient and they've developed pain, we've done an MRI scan, they've got a fracture, what do we do about this? Well, we performed a Cochrane review of this about 4 years ago now, which was published in 2018, looking at the literature at the time to see how we should manage patients. And actually, there were no studies in this Cochrane review that actually adequately addressed any of these questions. So we really have very little evidence to base the management of patients with RRIFs on. The study also showed that there were actually no studies describing the qualitative experience either of patients with RRIFs. And these are just some of the comments from our patients where we've done some work around developing a patient-reported outcome form for these patients, although it's still in development. But these are some of the comments that patients make around their insufficiency fractures. So the effects of losing mobility when you are a fit person are devastating. The pain stops you moving. I'm not sure how fragile my bones are. There's a real strain, and there's no physio or little knowledge of what we can do. So there's certainly a big dearth of qualitative experience. So one of the things that we have suggested in our quality standards to help with this, and research into this is ongoing, is that all patients who do have a symptomatic radiotherapy-related insufficiency fracture should have their pain severity and pain interference scored using an appropriate tool. We should suggest assessing their mobility, for example, using the short musculoskeletal function assessment and the quality of life assessment. And this will help going forward to try to assess the impact of any interventions that we use, and useful from a research perspective. So how do we manage patients? Well, again, this is data from a meta-analysis from 2020 describing how patients in the literature have been managed with radiotherapy-related insufficiency fractures. So what they showed that 60% of fractures in their analysis were symptomatic, although again, this depends on how they were diagnosed, and 85% of the patients actually had conservative management and did well with this. So the vast majority of patients required analgesics. Some required surgery or hospital admission, although this was the minority. There was a percentage at the start who were advised to be on bed rest, although the efficacy of this, I think, is unclear as well. And around 6% ended up on bone-directed therapy, such as bisphosphonates or teriparatide. So I have to emphasize again, this is just a description from the literature. It's not based on any evidence. We have produced a small management table for your guidance, and I'll just go through this in a little bit more detail. I know that's a little bit small. So the main thing about these patients is to provide reassurance that this is not a recurrence of the cancer, the fractures are not related to the cancer, they're related to the radiotherapy, and that the natural histories of these fractures is that they resolve over time with conservative management, and also that we don't think at the moment they predict having any further fractures, although more work is required around that. So you could be relatively reassuring to the patient and provide some information about that. The second most crucial thing is around how to manage the patient's pain, and we have got a very nice section on pain, so I'm not going to go into this in any detail within the rest of the guidance, which I think you'll have a talk about today as well. And then the next thing that we do is around the rehabilitation. So ideally this is done in conjunction with a physiotherapist, although again this can be difficult to access, particularly access people who have expertise in this. So it's important that we assess the function and pain, and if they are in a significant pain at the beginning, we would suggest rest and then slow mobilization, but always keeping the pain score 24 hours after the immobilization at a reasonable level. So low impact cycling and walking and strength training, and these can be facilitated using aquatherapy and ultra-gravity treadmills if they are available. So the second thing that we should do is then look at the known risk factors and try to address these. So we suggest that all patients have an adequate oral intake of calcium, and that this is replaced if required, and an adequate vitamin D, that they have good nutrition, and smoking cessation and alcohol intake within limits as appropriate. Also, if patients are postmenopausal, they should be prescribed estrogen containing HRT, providing there are no contraindications. So what we also do for all the patients that are referred to my service with fractures, and I think this is good practice, is to perform a bone mineral density scan. We've already said that the patient doesn't have to have osteoporosis in order to develop fractures, but sometimes the patients do, and therefore they may have a high fragility fracture risk as well. So if a patient has a low bone mineral density and also has a high fracture risk based on FRAX, then in that situation I would consider treating with anti-resorptive therapy such as bisphosphonates. If they don't have a high fracture risk, though, I would not use bisphosphonates for the management of radiotherapy-related insufficiency fractures, and also I would not put radiotherapy-related insufficiency fractures into the FRAX score as a risk factor, as we have no evidence that it predicts future fractures. Some patients we may be tempted to treat with a teriparatide or an anabolic agent, as we know that this builds bone, but actually we don't have any evidence for this either, apart from in mouse studies, and we do know that teriparatide is currently contraindicated for patients who've had irradiated bone, so it's very difficult to use that at the moment. So just in terms of the audit standards around patients with RRIFS, we recommend that all patients with a symptomatic radiotherapy-related insufficiency fracture should be referred on to a metabolic bone or DEXA clinic. They should be referred for physiotherapy if required, for aids and advice around rehabilitation, pain management, as we've discussed, and also counselling around the distress. These fractures can have a significant impact on quality of life. So just to finish, that there are very few studies ongoing or in the past are prospectively looking at radiotherapy related insufficiency fractures, but we are in the middle of a clinical trial, a feasibility study to look at this and to look at whether we manage patients who have at high risk of fracture with prehabilitation program during radiotherapy and management of their bone health, whether this can in fact prevent fractures. So the preliminary results for this should be out in the next few years, and we're hoping to do a multi-center trial on the back of this. So therefore, just to summarize, this is our at a glance table from the guidance, and you should be able to read about this in more detail once the guidance are available. So we're just to emphasize that any patient that presents with pelvic pain should have an MRI, and this is a good sensitivity for picking up whether there's a radiotherapy related insufficiency fracture. We should assess these patients for risk factors and address those, and also look at their bone health in general and preferably refer on to a specialist metabolic bone service, and then reassure and advise around pain relief and rehabilitation. Thank you. I hope that's helpful. I'm always very happy to be contacted about any patients with these conditions or any ideas or experience people have with these. Thank you very much.